foster family, we have 10 pets. They are 3 Westies, Saffron, Belle and Beau, 5 tortoises, Herbie and Bernadette, Amy and Sheldon and Penny, and we have the 2 rabbits who are Poppy and Daisy. And the fact that there is several dogs I find really helps, because we've got several children and everybody can have a cuddle at the same time and everybody can get that attention really. The children that we've had and young people that we've had have often spent more time with the dogs initially, because you can have a chat if you want to chat, you don't get quizzed, you don't get asked anything, and they're just lovely company. So this is what we call the den, and it's our semi-independent room, but this goes down really well. It's got its own entrance, it's got its own set of rules. It is somewhere to practice being independent but safely. We're all in the house, they've got access to the house all the time. I've got a key for the den as well, so it's still one home, but this is a separate area for privacy. We've got rooms in the house for younger, under 16-year-olds. This is probably my favourite and most important thing, and it's our welcome book. So we don't really discuss this book, it's just left on the child's bed and in their own time they just go through it. But what is so important to me, because early days it can be so daunting and it's like, who am I with? And it's actually really nice to have a little bit of an explanation, and they also can create talking points. Because food and meals are such a high anxiety area for nearly all of the children that we've had, I like them to know what's coming, and I like them to be able to plan and not worry about their evening meal. So we have a Monday to Friday system, and on Sunday I'll plan out what we're going to have, and they simply just tick their name if they want it. And I have found that since we've introduced this system, I'm not getting asked at breakfast what's for tea, because children were obviously concerned, they were asking the question, and it's there, they open it up. And it's really lovely because spaghetti bolognese always goes down really well, and on Sunday you can hear the little whispers, I can't wait till Wednesday. Before a new foster child comes to join our family, it is an anxious time, but I would say it's more exciting than anything else. And we've got a lot of trust in the county council for matching us to the right placement. So before that child arrives, we don't question, are they right for us, because we're confident that they will be. I would say to people thinking about fostering to ring the local authority and ask as many questions as you can. When I tell people I'm a foster carer, a lot of people immediately say, I've thought about that, or I want to do that, and haven't. And I'll always question, well, why did you not make that call, or why did you stop? And it's often a fear that could be just, I don't know what the word is. it could just be resolved so quickly, and sometimes just asking questions and makes you realise that the things you're worried about aren't really there, or you can speak to somebody that's experienced it and gone through it, and have come out the other side and think, actually no, it is a really rewarding thing to do. I can't see myself doing anything different.
We're live, Chair.
Thank you very much, Noel. I would like to welcome you all to this meeting of the committee, which is being held remotely, with the majority of members joining the meeting from their own homes. For the benefit of the broadcast, I will now ask the clerk of the committee, Noel McMenamin, to explain who is attending today and the practical arrangements for this virtual meeting. Noel, please.
Thank you very much, Chair, and good morning, everyone. As well as Councillor Girling, the other members present in the meeting here today are Councillor Martin Wright, the Vice Chair, Councillor Richard Butler, Councillor John Doddy, Councillor Kevin Greaves, Councillor David Martin, Councillor Liz Plant, Councillor Kevin Rostons, Councillor Stuart Wallace, Councillor Muriel Wise, and Councillor Yvonne Woodhead. Healthwatch Nottingham and Nottinghamshire is represented at today's committee by Ajanta Biswas, and Martin Gately, the Council's Health Scrutiny Lead, is also in attendance. We're joined today by a number of attendees to inform our discussions. These are from ERS Medical, Simon Smith, Mark Shepherd, Leon Blackwell, Sean Deasy, Kelly Stoneman and Mark Merriman, who are joining us for the non-emergency patient transport services update item. And we will soon be joined by Dr. Keith Girling and Sarah Moppet, who will be joining us for the maternity services improvement plan item. So we'll have to be careful to refer to Councillor Keith Girling and Dr. Keith Girling when we get to that point.
It's all right, I'm the tall, good-looking one.
Yeah, indeed so. Oh, you put me through my count now. Here we are. Anyway, so the meeting is held in line with the requirements of the Coronavirus Act, even 2020. Do bear with us if we experience any difficulty with technical issues. If we do lose members from the call, then officers will seek to get them reconnected as soon as we possibly can, hopefully without the need to halt proceedings. Officers will inform the meeting if we're unable to rectify the problem and we need the meeting to be paused or adjourned for a short time. During discussions, I would also ask that members refer to a page agenda pack numbers where appropriate. We're referring to points in the papers, and to keep on mute while you're not addressing the committee, because this helps prevent distortion on the call. Thank you, Chair.
Lovely, thank you. Can I ask the committee if the minutes can be agreed? Item 1, please. Anybody against it? No, okay. Minutes last meeting held on January 26th, sorry, 2021. Apologies for absence.
We've no apologies, Chair. We have a full house today.
Declaration of interest. Hang on, let me change the page. Do any members or officers present have any disclosable pecuniary interest to declare? And do any members or officers present have any private interest, pecuniary or non-pecuniary, to declare? That's a no. Okay, item 5 then, Nottinghamshire non-emergency patient transport services. I welcome to the meeting and invite you to introduce this item in more detail.
Thank you, Chair. My name is Mark Shepherd. I'm the Associate Director of Commissioning for Nottingham and Nottinghamshire CCG. I've got joined with me a couple of colleagues that are responsible for the management of the contract with ERS, and then colleagues from ERS Medical as well.
Can I just stop you, Mark, please? Sorry.
Okay.
Do you have your camera on?
I thought I do, yes.
Oh, okay, it might be my screen then, because I can't see anybody on camera. Okay, carry on then. If you can see, we can see you.
Yeah, you are visible, Mark, to myself.
No. Okay, I can't.
Thank you. Sorry, Councillor Girling, it's obviously just you.
Yeah, that's all right. Don't worry.
That's not uncommon.
Yeah, so hopefully you've all had the opportunity to see the paper that was produced and the comments included within that from ERS Medical. What I will do shortly is hand over to ERS Medical to give you the majority of the information from today. But what I just wanted to do was just take the opportunity to say Obviously, ERS Medical took over the running of the non-emergency patient transport services in December 19, which is obviously a very busy time of year to start taking on patient transport due to the winter pressures. And then obviously the unexpected happened with the pandemic, and that's obviously made all health services very difficult to provide, shall we say. And I think it's safe to say that ERS Medical have stepped up to that challenge and have continued to work with the CCG and with our stakeholders across the health economy, and continue to give us a really good service, considering the difficulties that have been faced. Few things to point out, and the reason that there isn't an awful lot of data to share with you is that one of the directions of travel that we got from NHS England was to reduce the burden on all providers from a reporting perspective. So quite a few performance indicators were suspended, not only for patient transport, but for a number of services. And again, that was to allow providers to focus on the delivery of services rather than reporting on the delivery of services. Did you want an introduction from the people on the call, or?
Yes, please.
Yeah. So can I first introduce Leon and ask Leon to introduce himself?
Good morning, I'm Leon Blackwell. I'm an acute contract manager with Nottingham and Nottinghamshire CCG. I work under Mark Shepherd.
Sean?
Good morning, my name's Sean DC. I work for Arden GMCSU and support the CCG in management of the contract.
Kelly, can I hand over to you to introduce yourself and your colleagues from ERS Medical, please?
You can. Good morning, everybody. I'm Kelly Stoneman. I'm the Senior Operations Manager for the Non-Emergency Contract Service in the Midlands area. I'll hand you over to Simon Smith now.
Good morning, everybody. My name is Simon Smith, and I'm the Head of Care Standards for ERS Medical. And my team of clinicians and health and safety subject matter experts are responsible for the compliance and governance of our services across the UK. I'll hand over to Mark now, Mark Merriman.
Can't hear Mark.
You're on mute, Kelly.
You're on mute, Kelly.
Good morning, everyone. I'm just doing a little bit of syncing with Kelly because I'm in close quite proximity to where Kelly is, so I don't want to get feedback on the line. So good morning, everyone. A pleasure to meet you all. My name's Mark Merriman, Head of Operations for ERS Medical. Apologies for looking a little bit like Bob the Builder this morning. I'm on site in Staffordshire conducting some site surveys for a new contract that we're looking to mobilise that will go live in August. And welcome any questions that any of the committee members have. Thank you.
Right, have you finished your presentation? Sorry, because I can't see anything. I'm really not happy about this, but all I can see is initials flashing when people are talking. So have we finished with our presentation?
We've finished with the introductions, I believe. Thank you, Councillor Girling. What I'm going to do is hand over to Kelly, and we have a brief presentation that shows a focus on patient experience. So I'll hand over to Kelly. Thank you, Kelly.
Yeah, good morning. I think somebody's ready to share the presentation. Is he there? Has he disappeared?
Hey, Kelly, it's Martin. I'm just going to do my best to share my screen so you can see it.
Okay, thank you.
Just bear with me a moment because the work when we practiced it doesn't seem to be wanting to work now.
Well, we know it works because we've already seen it this morning.
I'm sorry, Kelly, it's not coming up onto my screen like it did when we practiced it earlier. I'm not sure what the problem is. I don't know. Can you proceed without it? And if I do manage to share the screen, then I'll just try once more.
I do have a printed copy in front of me anyway, so that's absolutely fine. So I'll start with the complaints that ERS have received throughout from the beginning of this contract, and we've received 121 complaints overall between the 2nd of December 2019 to the 25th of January 2020. So this transfers to work out at 0.06% of all regulated activity undertaken throughout the contract. I don't know if everybody has had a copy of this, but there is a graph that shows the different reasons for complaints, and I can go into a few of those later for you if anybody has any questions on them. So due to government guidance, we have had quite a lot of testing and trying times to undertake the patient transport service. We've worked very well with the CCG, lots and lots of communication throughout, and along with all the acute trusts, we continue to have our meetings through Skype and fix problems. And let me assure you that there's been problems.
Sorry, Kelly, it's Noel. Just to interrupt, we are now showing the main issue of complaint slide on the meeting, so you can talk to it with councillors being able to see that, or those who are able to. So thank you. Thanks for your patience.
No problem, lovely. Thank you for that. So as you'll see, there's quite a lot of different reasons on there for people to complain, so different headings. So we have a system in place that logs all these complaints, and we obviously go back to the complainant, and we have a fully upheld, which was fully ERS's responsibility, not upheld or partially upheld. And I have got some of that written down. There we go. So such as fully upheld, ERS full responsibility, lack of communication around estimated times of arrival, and we take full responsibility of that. Not upheld, so a lot of these members of the public's complaining about our drivers, but we have a system called crystal ball tracking. So we check all the tracking evidence on every vehicle if a complaint comes in from a member of the public regarding any of our drivers. So partially upheld, so lack of patient understanding around the KPIs and not enough information or communication given to the patients. So we found at the beginning of the contract that we had a few complaints come through from the renal departments, and we found that there had been a change in the original KPI. So we worked alongside the renal departments. We went in and met with the renal leads and communicated the new KPIs to them for that to be communicated to the patients, for the patients to have a clearer understanding that the KPIs had changed. So month on month from the beginning of the contract, we've seen a decline in complaints. This is down to we communicate more with the patients and with the different departments, obviously. We did see a little bit of a rise in complaints when the government guidance, there was no eligibility criteria for patient transport. So everybody was entitled to non-emergency patient transport for a while. And then when that was reintroduced in August, it was again the patient's lack of understanding. So for instance, they'd had transport in June, but they weren't allowed to have transport in August. So that was just a bit of work with through ERS to communicate this to people as they were phoning up to complain. Again, down to communication. And we do a lot of that. ERS Medical, I feel we do communicate. We communicate with everybody throughout this contract. We've worked with the CCG for extra funding for extra vehicles due to the activity levels and the social distancing on board the vehicles. So we recognised very early on that we were going to have issues because of the social distancing that was put in place, and we worked with the CCG, and we now have extra funding in place for extra vehicles to be able to continue running the service. Priority was given to patients that were being discharged from hospital. Now, this was again guidance that we were following. It wasn't something that ERS put in place. It was guidance that was given to all patient transport services. So we saw a rise in patients that had gone for an outpatient's appointment and they were delayed in their journey home. And that was down to, we were having to prioritise the discharges to have patients go home from the hospitals to free up the bed capacity so the hospitals could continue running. We've managed to get, what's that percentage? 84% of our staff vaccinated. They've had their first vaccination for COVID-19. 17 staff in total, so 8% of our staff have declined at this present moment in time to receive their vaccine, and that's down to their personal reasons. And we have 8% of staff that are still waiting to have their vaccine, but due to having COVID, they're unable to go and have their vaccine as of yet. We've had an average of 5% of COVID sickness across ERS Medical. We've been able to manage that by bringing in third parties, staff covering with overtime, etc., just to continue running the service. We had a big project at the beginning of COVID when the NHSE instructions came in that all non-emergency patient transport vehicles were to be installed with bulkheads at the front of the vehicle. We managed to get this done quite quickly, really, and that was again with help from the CCG for funding to have these installed. And we also have we also fitted intercoms, and that's not a requirement from anyone but ERS Medical, and that's so that if there is a single person driving, the patients can still communicate with the driver through the intercom, so the communication throughout their journey is still there. And I don't really feel that I have much more to say, but I am obviously open to questions.
Thank you, Kelly. There has been actually one question popped in the chat. Councillor Doddy.
Can we go through me, please, rather than do it in the chat? If we've got questions, then we ask the question so everybody can hear the question. I've got two hands up at the moment. I've got Muriel first, please.
Actually, I think Martin was before me, Councillor Girling.
Well, if you go first, Muriel, I'll do Martin after.
Okay. Oh, thank you. Thanks very much for the presentation. And I appreciate that we're looking at the contract running from a strange time, aren't we? You know, largely beginning as COVID hit us, really. So perhaps some of the questions, the general questions that we might ask about a contract really don't apply particularly. In terms of and I appreciate that the number of complaints that you've received are pretty small compared with the number of journeys that the staff have been involved in. But in terms of the complaints, one area that I was interested in was the what's put down as human error, and I'd just like to hear what comes under that heading rather than under the other headings. Yes. Because as well as being a county councillor, I'm also chair of a network in the county of people with various forms of arthritis, and some of the soft information that I get is about the sort of an area of misunderstandings about what people's mobility issues are when they need transport to hospital. For example, a situation recently where someone using an electric wheelchair, the vehicle came and it wasn't a vehicle that could accommodate her wheelchair, so more of a scooter that she was using, and she thought she'd given information pretty clearly as to what vehicle adaptation she needed. So that sometimes that's an area of concern. The other that was an area of concern with the previous contract was around maybe the softer side of key performance indicators, that people who went regularly for dialysis and so on found the non-emergency transport really satisfactory. And maybe there's the impression that drivers got to know these people, and that sort of the service was pretty consistent. More concerns and complaints were raised by people who, for example, an older person with some issues about memory and understanding when to be ready, found that some drivers just drove off when they weren't at the door completely ready to get into the transport. And I wondered if those sort of issues about the kind of the flexibility around a driver picking someone up around the time they gave to that particular activity, and what area of tolerance there was in terms of assisting people into their house or bringing them out of the house to the transport. So yes, those areas I'd be interested to hear a bit more about. Thank you.
Thanks, Muriel. Do you want to answer that?
Is that over to me? Okay, so
Yep.
yeah, the human error is sometimes it is down to the booking, and it is maybe sometimes the questions haven't been asked clearly. We have put quite a bit of work in with the contact centre in Nottingham to for them to understand more, to ask further questions so that we do get correct information from people. And that's happened quite recently because we did pick up a trend of complaints. So like I said, extra training was put into place for them to go into things a little bit more clearly with patients that were calling. A few of the human error is we have the online booking portal where the nurses book the transport themselves. And what we also found was the nurse was asking the ward clerk to book the transport, and the ward clerk didn't have the full information. So they were in with limited information for that patient. We've tried to work quite closely with the acutes for them to do further training with their staff as well. If they don't know the full information of the patient, don't book the transport, try and get the full information first, because it could result in an aborted journey and a patient having to wait longer for that transport. So we have put in quite a bit of work with the acutes around that. ERS Medical train their staff that we do assist patients in and out of their properties. Nobody is left at the gate, nobody is left at the hospital door to make their way to the clinic. All patients are taken and collected to and from all clinics, all appointments, and in and out of properties, unless of course the patient does insist that we leave them at the door, but we would wait for them to go inside and close the door. We would walk them directly up to the door. If there is any concerns about we've arrived to collect somebody and we haven't sent the correct vehicle, we expect our drivers to report that directly through to the contact centre, and then we would try our very best to send out the correct vehicle straight away. If this is not possible, we phone the clinic, the hospital, we phone them direct and ask if they would accept the patient a little bit later, or do we need to rebook the appointment, and we keep that communication with that patient so the patient is aware. We don't expect them to phone and say, I can't get because my transport's not correct. we do all that for them. Does that answer things a little bit more clearly for you?
Yes, that's really helpful. Thank you. I mean, a local voluntary transport organisation in Nottingham stopped taking phone bookings for transport because of misunderstandings on the phone, and asked people always to put into writing their request for transport. And that was a disincentive for many people because of the timescales of needing the transport and so on. But I can appreciate that bookings over the phone aren't easy. I think your development to ask staff to ask further questions and to give that first referral plenty of time to be sure of what's needed, that seems a really positive step forward, and thank you.
We also, just to go on a little bit further on that one, we recognise that patients have regular transport, but we wouldn't just go on their previous mobility from a
No, that's right.
We would double check any mobility changes and make sure that that's been changed in the booking.
Yeah, thank you. That's really helpful.
Thanks, Muriel. Thanks, Kelly. Right, I'm having little difficulties here, so when the hands go up, it normally the one who put it up first goes to the top. That's not happening. So if I call somebody first and they were, you weren't first to put your hand up, don't worry. I've got Councillor Martin Wright next, please.
Chairman, I'll forgive you on this occasion. Could I ask, please, firstly, what does ERS mean?
Emergency Response Services.
Right, lovely. That's got that sorted. Next, congratulations on your list up or lack of list of complaints. 121 complaints out of 190 transfers is remarkable. Just to interrupt, I'm getting a bit of feedback here. I don't know if anybody's got their speaker on when they shouldn't have it on, but I'm getting feedback. Anyway, congratulations on that. Congratulations on the amount of staff who's had the first virus vaccination, and look forward to the other 8% who are waiting to have theirs. What can ERS do to try and persuade the other 8% who have declined a vaccination? Because at the end of the day, I know it is a personal choice, but at the end of the day, it's protecting them as much as it's protecting the client, so to speak. And my last question is about performance, your performance as measured against the previous transport service we had before, which you took over from. Are you able to compare your complaints against their complaints? Because we know they had quite a few. That's my last question. And again, congratulations. There's a gentleman on my street who lives 50 yards from where I live. He's a 3 times a week customer for dialysis with the ERS. He has nothing more but praise for the way they treat him. And he asked me, actually, because I told him what was happening today, and he asked me to pass on his thanks to ERS for a fantastic service, and it is much better than the one before. Thank you.
Thank you very much for that. That's really nice to hear. I'll answer the question on the outstanding staff members regarding the vaccine. That is down to fertility. So they feel that there hasn't been enough information out there on whether it could affect fertility later on down the line. So that's the reason that we have 8% of staff that are currently still declining to have the vaccine. We are working with them, and we are obviously keep asking, and as soon as they want to have the vaccine, we'll get them booked in. But at the moment, it is fertility.
Kelly, it's Simon Smith here. If I can just expand on that response, Councillor Wright. So this is a national problem for us, as well as any healthcare provider and any part. So there's a couple of things going on here, and Kelly's absolutely right. Fertility in young females is a concern, majoritively. There's also the BAME question that has to be addressed, and we've seen certain demographics in that area turning down. So we're actively working with our head of communications and marketing, and we've recently put out a video this weekend on LinkedIn trying to advocate the use of the vaccine across all demographics of our staff workforce, and to signpost staff who have additional questions back through their GPs to seek further expert medical advice about the pros and cons of taking any specific vaccine. So it's absolutely something that we recognise, not just in Nottinghamshire, but across the organisation as being important. And we follow the national lead through the government on sort of advocating uptake of vaccinations. But we have to be sensitive to the individuals' fears on that. And again, we've taken the national lead on what other healthcare providers would do with staff potentially to support them if they can continue or persist in saying they do not want the vaccine, because they do have that right of choice. Hopefully that just expands a little bit more on the difficulties with vaccinations, but we actively track twice a week our vaccination programme across the UK to identify those members of staff that have declined the vaccine. And the number's fairly static now. We're not seeing a massive increase. We're hoping to see in the weeks and months to come that number will start to decrease as more information comes out across the organisation. But the vaccination programme is absolutely been supported by the acutes in the CCG. So we couldn't be doing this without their support. So it's really important to sort of thank the CCG for their support in getting ERS medical staff prioritised through the JCVI and the sort of 4 tiers of people that were prioritised through the government's programme. So thank you for that.
Chairman, if I may, Chairman, the question I posed regarding patient satisfaction as compared to the previous provider, I don't know if anybody at today's meeting has that information, but it would be helpful if you could relay it to us if you do have it.
Yeah, certainly, Councillor Wright. It's Mark Shepherd from the CCG. I think it'd probably be a little unfair to ask our colleagues from ERS to comment on the previous provider, but we did anticipate this question, so I'm going to actually ask Sean to just give us that data, because I think you've looked back at the previous 12 months, haven't you? Thank you.
Yes, I have. I carried out the same role under the Arriva contract, and I can say both from an anecdotal point of view as well as an operational point of view that the contract for ERS is far better than it was. In terms of complaints, the amount of complaints that ERS are running is about 50% less than the level of complaints that Arriva got. And part of that is the earlier comments about ERS are on the front foot. They deal with complaints very quickly. They put things in place to stop them happening again. And that just helps the level of complaints to stay low. Hopefully that answers your question, Councillor.
Yes, thank you very much indeed. Thank you, all of you. Thank you.
Brilliant, thank you. I've got Councillor Greaves next, please.
Thank you, Chair. I don't know whether anybody could see me because I can't see anybody else. I could just see their initials in boxes.
Same as me. That's same as me, Kevin.
Oh, right, okay. What plans are going to be put in place for when we return to normal transport activities post COVID? Will there be any extra funding for this, if any at all? Thank you, Chairman.
Thank you, Councillor Greaves. It's probably, again, slightly unfair to ask ERS to answer that question, so I'll try to do my best. There is a level of sort of anticipation within the answer to this. We are currently funding additional activity with ERS because of the COVID rules that have been put in place. And that has been recognised as a requirement going forward. We do know that those rules around social distancing and minimising patient contact within the vehicles have caused problems. They do mean we have probably more delays than we would like, but again, ERS have done a sterling job in responding to that. And certainly for the next period, that additional funding will continue. There is the issue as we start to return to normal elective services, so more and more outpatient services, more and more hospital appointments, that we are going to need additional patient transport services to cope with that, and that is being planned for and considered, and will also form part of the recovery finances and funding that we are expecting to be drawn down from the central government into next year. So the answer to the question is yes, hopefully. We don't yet know how much, but we will work very closely with ERS and the system stakeholders to make sure that we have a PTS service that's fit for purpose. Hopefully that answers your question.
Yeah, Kevin, with that.
Thank you very much, Chair.
Thank you.
Does anybody who hasn't spoken have any further questions? Okay then, right, well, I'll just sum up then. So thank you very much for coming to see us. Obviously, a very busy time for you. I think what we've assessed here today is the fact that the service is being run far more efficient than it was previously. So well done for that. And I'm particularly impressed, and I think the committee are, in the fact that you respond to the complaints a lot quicker, and also then start to adapt in terms of making sure that don't happen again. So well done for that. I do have concern about those that do not have the vaccination, and I understand that they have a right not to do that, but we have a responsibility in this committee to worry about the welfare of our residents. So I think that's a difficult balance for you to have, and I hope that we can get the evidence put forward that it doesn't affect the things that worry people, so that they can get vaccinated and then protect the people that's in those vehicles. So thanks very much for coming. I think we can look at maybe you coming back in a year's time. So hopefully by then, he says, touching wood, that things are back to some form of normality by then. And then we can see how the service is run under normal circumstances. So are we all happy with that as a committee? Anybody opposed to that? Lovely. So thank you very much for coming, and I'll see you in about a year's time. Thank you.
Thank you very much, Chair.
Thank you.
Thank you very much.
Thank you very much.
Okay then, that takes us on to item 6. I welcome to the meeting and invite you to introduce this item in more detail so there's no confusion. There is a Dr. Keith Girling here as well as a Councillor Keith Girling, so I'm sure we'll manage to get through it. Thank you. Who's introducing it?
Good morning. Should we just introduce ourselves? So
yes,
my name's...
please. I can't see anybody, so you'll have to forgive me. I'm running blind here.
My name's Sarah Moppet, and I'm the interim chief nurse at NUH.
And I'm Dr. Keith Girling, the medical director at NUH, and Sarah will be starting off the presentation this morning.
So we're both going to take you through some of our improvement plans, but if I might start by saying thank you for having us. We are very, very willing to share all the plans that we have and take detailed questions at the end, and I'm sure that you will have some. So we'll try not to talk for too long, so that we save plenty of time for you to ask us questions. I think the first thing I need to start by saying is a really clear acknowledgement that clearly the service that we've been providing to citizens of Nottingham is not what they should expect or deserve, and we are very, very aware of that. I hope that by the time we finish our time with you, you will feel assured about how seriously we've been taking the improvements in maternity, how committed we are to building the very best maternity services that Nottingham could offer. So just to start by saying, you'll probably be aware that there's an awful lot happening nationally with maternity. There's been various national reports out, and there's an awful lot of information that we have as an organisation in terms of our maternity services. So our improvement plan is a very big document, because what we've done is we've triangulated the information that we've had from our regulators, from coroners, from the things that we've described in the report, with a lot of the national recommendations that have come out, to make sure that our improvement plan is considering all the elements of maternity and the national advice as well, in terms of where we should be improving services. Just to start at the beginning, in the paper we've described very briefly the governance framework that we've put in place as an organisation. So you'll note that there are 5 key work streams which we've divided the improvement plan up into. Each of those work streams is chaired by an exec director, and they report into oversight committees which feed up to Trust Board. But it probably is important to draw your attention to the fact that there is also a system assurance committee which we are accountable to, and as execs reporting each month in some detail the progress of the previous month and the plans for the following month in terms of maternity improvement. So if I may, I'll just highlight a few key areas from the work streams, and then Keith is going to highlight some of the safe practice and governance areas. So if I start with immediate actions, I guess the work that we've been progressing has formed 3 main areas in terms of focus. So when we received the CQC report in October, there were some immediate actions which we took as an organisation, which I'll describe it in a minute. Then part of our improvement plans focus on responding, as I've described, to regulatory requirements and some of the feedback we've had and the national reports. And then the 3rd area of focus is very much around quality improvement. And I described the 3 areas because I think it's really important to give you a flavour of the different types of work that we've been doing as part of improvement, because they're all really important. So there's some actions which you just have to take to make services safe, that absolutely are the right thing to do. But also, as an organisation, we've been working really hard to build a maternity department with the right infrastructure, support, development, training, leadership, which enables our staff to develop and provide the very best maternity services. And that's where some of the bottom up, putting some of the processes in place to really ensure that our staff can design and co-create services alongside the users of our services, because that's how we will build the very best maternity services in Nottingham. So in terms of immediate actions, one of the work streams you'll notice is called Safe Today. And that's very much about making sure that we are able to respond to any service pressures on the day, in the moment, that we are able to protect one-to-one care for mothers coming into labour suite, and that our senior midwives are able to have oversight to ensure everyday safety. So we've put in quite a detailed process of checking staffing, checking any what we call red flags, and making sure that we've got a really robust policy in place to respond to any concerns, so that our staff on the shop floor have the tools to respond to service pressures, because there is a national shortage of midwives. So we do have quite a lot of midwifery vacancies, and part of our response to the concerns has been to increase our establishments in line with some of the national recommendations. So in a way, we've created some more vacancies. we're doing really well actually at recruiting to them, but there aren't hundreds and hundreds of midwives out there nationally. So it is, whilst it's improving every month, it is slow progress. And we've been taking some other longer term actions. So we've been working with the Nottingham University. We've increased the number of midwives that they're going to start training. But of course, all of these actions, some of them take longer to come to fruition. So we now have in place an interim director of midwifery, and she is a very experienced director of midwifery who has worked with maternity departments who have needed to improve their standards. So she's got a lot of experience in helping departments to improve very quickly. We have done an awful lot of work looking at leadership development, doing some one-to-one coaching with some of the midwifery sisters and leaders across the department, and really considering with them what would be helpful in terms of helping them support their teams develop the best services. Shall I keep going and take questions at the end? Would that be okay?
Yeah, just you finish your presentation, then we'll open it up to questions.
Lovely, thank you. So I think the other thing which was part of an immediate response, but then also some longer term actions, is around some of the infrastructure we've put in place around training, increasing the number of training posts that we've got, and re-looking at the way we were training staff, the competency assessments that we have put in place to really assure ourselves that the staff have understood the training and are able to provide certain skills to the required level. We've looked at how we induct and the preceptorship support that we provide to new midwives, and how we assess their skills. And then we've also looked at a model we have across the organisation called shared governance, which is where we develop our frontline staff to be able to come up with ideas for improvements. And that's a system that we already had in place, but we've been working really hard to make sure that a shared governance across the various areas of maternity is working as well as it can. So I'm just going to hand over to Keith now. He's going to take you through some of the safe practice and governance changes that we've made in response to the feedback that we've had.
Thanks, Sarah. So just to build a little bit on what Sarah's been saying, when we first instituted a Safe Today programme that Sarah's described in order to ensure that women having care at NUH were as safe as they possibly could be. And then we stepped back a little to listen to the staff and to the women using the service, and to link in with Maternity Voices partnership to get feedback around the service. And we also did a themed analysis of 4 sets of data. So the Ockenden reports that came out nationally, the healthcare safety investigation branch reports that we've had, the coroner's reports, and our own serious incident reports. And from that, we identified that we needed work streams around safe practice, around people, staffing and training, and around governance. And those are the remaining work streams that you see set out. Within the safe practice domain, we identified 11 work streams that would need attention. And within those 11, we prioritised 5 for initial activity, improvement activity, because they are the areas that are of greatest concern to the safe delivery of babies in the units. So those 5 areas look at the antenatal assessments and risk assessments as CQC have described to us. They look at fetal heart rate monitoring, the CTG, so-called cardiotachograph, the CTG monitors, and there's a number of strands to that. They look at the induction of labour, postnatal care, and postpartum hemorrhage. And all of those 5 work streams are now have progressed significantly. That has included the release of a significant amount of IT equipment into the maternity service and upgrading of IT equipment, and notably the change for community midwives to using the same electronic recording system as the trust uses, such that there's instantaneous and contemporaneous information shared between community and acute setting midwives around care of women. And we're already starting to see the benefits of that change. Within the fetal heart rate monitoring, that has resulted in a significant amount of training for midwives. So we have 2 training packages. We're at over 90% completion of the first training package. The second competency package is currently sitting at 30% and continuing to increase each week. It's a much more substantial package than the first package we released. And we have also procured new fetal heart rate monitors, with 14 of those machines being now ready to release into the clinical area, and we are in the process of looking at how we procure an additional 38 machines in the next few weeks. So there's been an awful lot of work going on around those first 2 pathways. And as there has been within the pathway around postpartum hemorrhage, which has been another area that the CQC picked us up on. And so we are not yet at a stage where we can show improvement in all of those, because that work has been introduced, but not yet. We're not yet fully seeing the outcomes from it. In the governance domain, the CQC were concerned that there were incidents that were being reported which met serious incident criteria, but not being reported as serious incidents. And so we have gone back and done a retrospective look at the last 12 months worth of incidents ourselves, and we have also had external review of our incident process, and that has highlighted a small number of additional cases which we will be reporting as serious incidents, and we will be looking at the themes from those in addition to the other work that we've already been undertaking. We're very pleased to have had help from the National Maternity Improvement Programme, and so we have a very experienced director of midwifery from another trust working with us for 1 day a week, and we have a consultant obstetrician from a different trust also available to us to support obstetricians and challenge us around areas of improvement. So we've had a significant amount of external support into the department, into the departments. We have established really a very clear governance programme. We've started a number of work streams to improve safety, and our ambition is to get to a position where we're CQC to come back and look at it again a year after they came previously, that they would see a significant improvement, and we would move from inadequate to good is what we're aiming for. I'll pause there, Councillor Girling, and then take questions if that's
okay. Thank you very much. I've got Muriel, Councillor Wise first, please.
Oh, thank you both. I mean, it's clearly a very complex and wide-ranging area, isn't it? I've got 4 questions, if I may. One about midwifery. I had a grandson born at the City Hospital 16 years ago, and like any of the grands, I was faffing around, and my daughter was in there for quite a while. And when I went up to the desk to ask what was happening, one of the senior staff said to me, "The trouble is we don't have enough midwives. We can't cover the hospital." It was a hotel resource at the city at that time. She said, "I either have staff at the hotel or I have staff here, and I just don't have enough staff." And she told my daughter this, and I thought, this is not the time to tell someone that you haven't got enough staff. But I did understand, and I just wonder why, because people speak of it as being a very rewarding area of work in nursing. I just wonder why we still struggle to get a sufficient midwifery. Is it lack of money, or is it? Yeah, so that was my first question. The other 2 are kind of broad questions. I know in a way you've deconstructed the issues down to the pathways that you need to look at, but I have 2 broader questions. One is about, why are we in this? I know there's a national issue, and there are other trusts that are in much worse situations than yourselves. But locally, do you have any view about why we're in this situation now? I seem to recall some reorganisation of maternity services a few years ago, whether it was to bring all the services onto one site or to, in retrospect, was that reorganisation helpful, or is it led to another question about how maternity services should be organised across the sites? And following on from that, just broadly, what do you think the broad challenges are? And I know you're picking up a load of work. Is it a cultural issue? Is there something broadly that you both see as being the thing that across the board through all these pathways is the kind of basic challenge that needs to be faced, and which perhaps we can to help you with? And my last question is about postnatal care. We've had a discussion about this at Health Scrutiny already this year because of the number of women who are experiencing significant isolation after the birth of their children. I know it's had media coverage as well. I just wonder, do you see that when we're in a position to make up for this loss of attention these women had? I think some of them are now saying, can you give us extra support now that our babies are getting on for 8 months, a year old? Can the health service make up for lost time in giving us the time and attention that we didn't have when we had the minor concerns about our children's development that didn't get answered? Yeah.
Thank you.
Thank you.
Keith.
Thank you. Sarah, do you want to start off with staffing?
Yeah.
And then I'll pick up 1 or 2 of the other bits.
Yeah, that's great. Thank you. Really good questions. So why haven't we got enough midwives? It is a national problem. I think years ago when we had the bursary, there was a cap on numbers. It's quite difficult for universities to increase their numbers. Then we sort of went full scale and we took the bursary away for a few years, and now it's come back. And the simple answer is nationally we haven't been training enough. There's been a lot of developments in maternity, such as continuity of care, which require more midwives. One of the opportunities that COVID has probably given us actually is the universities are really working with us to help increase the training numbers. So I think nationally we haven't quite got the calculations right. Locally, we haven't really been training enough midwives to meet our requirements. That is a picture that is beginning to change, and actually if you look over the last few years, midwifery has nationally has increased the number of midwives it is training. I think the other thing is the honest answer is we've got more work to do with our retention. Most of our midwifery students, actually, we do retain them. So out of all the midwifery students that started in the last 18 months, we've only lost 3, and 2 of them were relocations for personal reasons. So pretty high retention rates when the midwives do come and work with us. But I think at the other end of the profession, so midwives coming up for retirement, it's one of the strands of work that we've been doing as part of our improvement plans is looking at more flexible working, looking at why midwives might want to retire early, what we can do to retain some of that incredible experience, looking at sort of legacy type mentorship roles. So I think there's more work to be done to reduce the turnover and retain the midwives as well. And we do also need to increase the number that we're training. So Keith, shall I hand over to you, and then I'll probably come back and help with some of the other answers at the end.
Yeah, thanks, Sarah. And just to build on that answer a little bit more, our methodology for understanding how many midwives we need has changed as well, as the population need has changed. So historically, we've based midwife numbers around the number of births. In the last year or so, it's been very clear that we've needed to look beyond the numbers of births to the acuity of births and the level of support that women are needing. And we know that we have a higher proportion of women, for example, with diabetes, that are now needing care during childbirth than there were previously. And those changing demographics and the changing population needs is meaning that we're needing more midwives than we needed before. And so the assessment that we did last year, which is now called Birth Rate Plus rather than birth rate, looks at the acuity of the women that we look after. And that's where we identified that we needed another 60 whole-time equivalents when you took into account the acuity of the women as well as the number of births. And so although the birth rate is going down, the number of midwives we need is going up, along with the other things that Sarah's talked about. I think many of us have been asking ourselves exactly the question that you've asked about why are we where we are now. We have known and we have been concerned that we have not had the maternity services where we've needed them for some significant time. We have done a number of interventions over the last couple of years with maternity services, including some culture work, where we had an external company come and support us with a culture diagnostic and some cultural survey, and then cultural interventions with different staffing groups, which was well received by the staff at the time. But I think what we're conscious of is that the changes that were made at that time were not properly embedded and were not followed through. And I think we have to learn from that as we go forward. I know one of the questions that the committee was very keen to know was how would we be assured that we're not going to get here again? And absolutely, there's a lot for us to learn from our previous attempts at what we've done in maternity and how we've supported maternity. And the development of our leaders, as Sarah has described, and the support and coaching and the development of those individuals is really key to ensuring that the changes that we make are embedded and maintained for the future. So absolutely, there's a cultural element here as well as other things. In terms of reorganisation, there is a very strong ambition to move to combine the Queen's and the City maternity services into a single unit. That hasn't happened. We have separate units still at the City and at the Queen's, but going forward there would be a strong ambition to combine the two because of the benefits that would result in being able to provide care for women in one centralised maternity unit. But that's outside the remit of this conversation at the moment. The reorganisation that you may recall is that there was a separate community midwifery service and an acute trust midwifery service, and those two services combined a number of years ago. Again, what we have become really acutely aware of through this is that the IT systems were never changed to allow a common record for the woman. And that's the piece of work that from early January we got onto to make sure that every woman that's booked now is booked through a common record that everybody can have access to and see, and that's something that I think is a really significant change. And in terms of postnatal care, I think the points you make are really well made, and we're very mindful of them and the impact that COVID particularly has had in the last months of reducing face-to-face visits. I'm pleased to be able to tell you this morning that it's been confirmed to me today that we'll be recommencing face-to-face postnatal visits from next week. So this is a big step forward for women in those first few days after delivery. So not plenty still to do, but working in the right direction. Sarah, did you want to add anything to that? I see we've got a number of hands up.
I'm happy to take other questions if.
Okay, I've got Councillor Wallace next, please.
Thank you, Keith. Thank you, Sarah. I had a number of questions to write down, and then you actually made the one question that I think is so crucially important. And you said you wanted to, how did we get here and how do we ensure we don't come back? I've had a lifetime in compliance. You can call it quality assurance, you can call it what you like, but it is always the heel of all organisations, and they all crash down because it's not looked at. And I look at your list of governance and oversight, and I don't see a compliance or whatever we want to call it sat there at the board level. May not be the same fighting power, but he or she sits there as an oversight telling the actual board members what has to be done and what systems need to be done. Not in specifically, but these things are being looked at. And I congratulate you on your entire lists that you're going through, and you're doing this, and you're doing this, and this will give us that and that, etc. But my experience also tells me, unless you have got this quality compliance, whatever we want to call it, riveted in at all departments, riveted in at all levels, what will happen is as you come to succeed in all of these areas and make it fully operational and good quality, you then immediately start to go downhill because people aren't continuing there to drive it. They've moved on. They've been taking on something more important and moved on. Because the question I must ask is, it's a retrospective one, how did you get here in the first place? How were the errors that were found that you're now coming to correct, how come they'd either never been detected or had been detected but never seen as important? And I worry when you say amalgamation of the two midwifery services, etc., but they haven't taken place. I mean, I suggest that it's going to run on fiscal matters, whether either of the two trusts can afford to have that chunk taken off them, etc., whatever the reasons are. But if that is a crucial thing, why isn't it being driven harder? And my final comment is, I'm pleased to see that everybody from the persons who cleans the floor in the wards and hospitals bit, etc., all the way through to board, have a right, can feel that they can open up and speak and talk about what's going off. And I've been in so many different banks, businesses, etc., who've all come up with the thing, well, our staff can talk. Well, you might think they can talk, but they're not likely to be talking unless you've got plenty of examinations coming through. So, well, I'm saying then in all those questions, all those concerns that I'm putting through, are we going to see compliance all the way through? Are we going to see that everybody understands the importance of having their 4 pennyworth, the people that work with them 4 pennyworth, the people below them work the pennyworth, in order to be able to get a more dynamic, because people are working their socks off, doing what they can, going home chuntering. We need to get that energy being forced back into the organisation. And that's a bit of a rant, but somewhere in there's a question. Thank you.
Thank you. Do you want me to start, Sarah, or do you want to pick up? So I'll start off, and really important points in all of that. So thank you. I think in terms of compliance, I think we would talk of governance and quality governance. And I think one of the things that we have become again aware of all our specialties, the maternity specialty has reported more in assurance to the Quality Assurance Committee than any other, because we've been concerned that things have not been quite right. We have gained assurance in the last year from national data sets from Embrace, which is a national data set looking at stillbirths and neonatal deaths, which shows that we are significantly better than the national median in both of those. The data always runs retrospectively, and so we've only just had the 2019 data published, but the 2019 data, 2018 data, and the years before have consistently shown that we have been better than average in both of those domains. And in the last year, we also had a PICA survey of women using our services, which showed that we had the best improved women's satisfaction with our survey of any units in the country. And so we took some assurance from those findings that actually what was happening was improving compared to where we were before. I think our deeper dives into the service since the CQC visit of last October have shown us that the local governance arrangements have not been what they needed to be, and they've not had the detail of the information that they needed to have, and that has caused us significant concern, and is one of the reasons why I think, exactly as you're describing to us, that the compliance at the local level has not been embedded or maintained. And so those local governance meetings have been absolutely reinstated with really thorough agendas and expectations, and we already have much greater assurance coming through from the specialty. And in fact, that's being reported to me from the consultant medical staff, that's saying that for the first time they're having a conversation they felt they should have had for some time around some of the aspects of what I think you're describing as compliance. The amalgamation of the two units is not entirely an operational financial issue. It is that the neither the City nor the Queen's have the capacity to be able to manage the full demand for maternity services without very substantial capital investment. And within the Tomorrow's NUH programme that I know that has been presented to you, one of the absolute ambitions is to realise that combined maternity and neonatal unit on a single site. there are several other drivers nationally that are pushing us towards an earlier reconfiguration of our neonatal intensive care services, but absolutely within tomorrow's NUH at the top of our priority list is resolving the amalgamated maternity units. And then finally, the point that you make about essentially psychological safety and freedom to speak up is absolutely fundamental to this. And we have been very appreciative of the work our Freedom to Speak Up Guardian has been doing to make herself readily available to all members of staff on a really regular basis, holding some open sessions for staff to access the Freedom to Speak Up Guardian, so that we can listen to staff in a completely safe and anonymous way, if that's how they would like to be heard, as well as the focus groups and the other communication that we've had with staff. So we have attempted to listen really carefully. I'm sure there's more to hear, and I'm sure that as people gain confidence in the fact that when they speak, people listen and actions are taken, we'll hear more and more come out over these next months. But there's certainly been a really a significant attempt from the organisation to make sure we are listening to our staff and to the women that are using our service. So I don't know if you want to add anything to that.
Probably just a couple of things. Thanks, Keith. The point around sustain. This is a long-term programme. This isn't just a year and then we've got to good and then we drop it. This is a journey to excellence as far as I'm concerned. And we have started to do, but there is more work to do, looking at roles, responsibilities, accountability, making sure that quality governance, there is real clear accountability through the operational lines at all levels. The other role that we've been working to strengthen is what we call the safety champion role. So there were roles around a non-exec director safety champion and exec safety champion, but also a obstetric and a maternity safety champion, and really making sure that those roles are implemented to the full, but representing the voice of patients and staff within the service, and really making sure that we've got that check and challenge right as part of our quality governance accountability. So there were just a couple of points to add to Keith's response.
Yeah, Stuart.
Yes. Yep. Thank you.
Lovely. Thank you. That's Councillor Martin next, then, please.
Yeah, thank you, Chair. Morning, Keith. Morning, Sarah. Thank you for your presentation. It's very good. I'm reading the key actions completed. So I'm very impressed with some of the stuff that's going off. So interim director of midwifery post. I presume that's progressed then. That's in place now. Development for senior leaders across both the City and Queen's Hospital. Can you just elaborate for me a bit what birth rate plus assessment is? And we've touched on recruitment already. Obstetricians, I mean, is that are we struggling with recruiting obstetricians as well as normal nurses? I'm particularly impressed with this process for identification and escalation of concerns. So how does that work? Because obviously in a maternity suite that can be a rapidly evolving situation, and the improved triage for mothers, that's another thing that's very, very important to do. Improvement in training of cardiography, that's another very important issue, because that can rapidly change in a maternity suite, the situation there. So and you developed competencies, can't say the bloody word now. Competency training. Is this across all staff? Because that's quite important, isn't it? Because a lot of the time you just have midwifery nurses wandering around, and they're not always skilled in the vast areas that there are sometimes required for that. And your review and implementation of revised serious incident processes, that's like an autopsy, I suppose, after the fact. You know, so that's a very handy learning tool. It's very sad for the people that have had to be on the receiving end of it, but obviously if you're learning from the process, then that's another thing. And I'd imagine the whole process has been exceptionally difficult over this last year with COVID as well, because not only have you had your staff self-isolating and all that, but the inpatient patients coming in as well have been equally as difficult to deal with. So how's that affected the programme? Because that's been quite crucial this year. I imagine you've learned a lot from this year over that issue. Thank you.
Thank you. Sarah, do you want to start with birth rate plus and midwifery stuff?
That's fine. So yes, you mentioned about the interim director of midwifery. Yes, she's in post, and we are also interviewing at the end of this week for a substantive director of midwifery with a degree of confidence that we've got suitably experienced applicants to appoint to that substantively. We have done an awful lot in terms of leadership development. There's a whole variety of offerings. I suppose that the only caution with that, I'm really conscious that these things take time to impact, to enable our staff to develop. But that there are, I can go through them in more detail, but there's a lot in place. And sort of mentoring and coaching for some of our midwifery leaders. In terms of birth rate plus, it's a more refined calculation. So it looks at so Nottingham takes a lot of the difficult, complex cases because we're a regional unit. So it's a much less blunt tool where it doesn't just look at how many births and therefore how many midwives you need. It looks at the type of cases and the complexity of the cases and the acuity of the unit. And that's one of the things that the escalation tool that you mentioned, that's one of the key changes that we've made in terms of our escalation, because the escalation policy requires the managers of the day to not just review the number of midwives, but to review the complexity of the cases they're caring for on the day, and therefore what the acuity is, and match that to staffing. So it's not just about numbers, it's about what you're caring for. Because actually our birth rate has actually gone down in Nottingham, but we still require more midwives, and it's to do with the complexities of what we're caring for. Also from a safety perspective, a lot of the national initiatives are changing the way that midwives care for patients. I mentioned in my presentation at the beginning an initiative called Continuity of Carer, and that looks at a team of midwives following mothers through, so that there's more continuity of care right from antenatal through to postnatal care. But that's slightly more resource intensive. So some of the modern, if you like, ways of calculating how many midwives you require take some of those things into account. And that's partly why we had a deficit of midwives in Nottingham, is because of the complexities that we care for. In terms of the escalation process, we did have an escalation policy in place, as you might expect. But what we've done is we've aligned it with the escalation process for the rest of the organisation, so that midwifery isn't an island on its own, that it is supported by the on-call infrastructure that we have in place for the rest of the organisation. And within the escalation policy now, there are clear action cards for staff at different levels. So there's an action card, for example, for the nurse in charge or the midwife in charge. When X happens, these are the things she needs to consider, and these are the people that she needs to inform. So we formalised the actions that our staff take to support them more, really. It provides them with a better supportive infrastructure to allow them to call for help when they need it, and to do that in a timely way, because we weren't as good as we should have been. So we really strengthened those processes. Shall I hand over to you, Keith, to talk about obstetric recruitment?
Thanks, Sarah. Yes, so we do have a significant number of obstetricians already in place, but the move towards effectively 24/7 obstetric consultant-led care and delivered care rather than led care requires us to increase our consultant base further. We are also looking to increase the number of antenatal clinics that are available in order to expand the amount of time that each woman would have with an obstetrician in the antenatal clinic. And that's all part of the opportunity to have greater communication with the women, and also to take more informed consent and a greater discussion of the woman's choices through the maternity care. And when you add up the amount of time that we would need in consultant time to be able to deliver that 24/7 cover, plus that increased outpatient cover, plus being able to do more development for trainees and for midwives, etc., into a package, then you come to require another 12 consultant obstetricians. And again, a bit like midwives, consultant obstetricians are not to a penny. We have managed to recruit a small number of locums, and we are looking to recruit these 12 consultants probably over a 2-year period in reality, looking to bring 6 or 7 of them in this first year, and then the remaining 5 or 6 in the second year. We have a couple of trainees coming off, finishing their training this year, in addition to the locums that we have, and then we'll be having some further trainees completing their training in the second year. But this is a very substantial consultant recruitment, and that is not inconsistent with every other maternity unit in the country that is also looking to increase the consultant numbers. And so there's a lot of competition for those people that are coming at the end of their training programs, but we're confident that we can recruit those people over a couple of years. In terms of COVID, if I can just pick that up, we have learned huge amounts across the organisation around COVID, and maternity has not been spared COVID, particularly in this second wave, where we've actually seen a significant number of pregnant women who are at time of delivery also experiencing COVID symptoms, and that has been really challenging for all the people caring for these women, but also for the women themselves, of course. And we have sadly had a small number of those women admitted to our intensive care units for a very substantial care. So this has been a really challenging period, and in addition to everything else that we've been managing.
Okay, you happy with that?
Yes, Chair. I'll just come back on the fact that it just listening to Keith Girling there saying, you know, how difficult and the process for teaching people to take on that role is quite important when you think about recruitment, especially nationally, because there's a shortage of nurses, as we know, across the whole range, doctors and everything. And that is particularly highlights the issues that you've been dealing with this year when you say that you've had people who have been heavily pregnant in the COVID wards. That really brings it home. So thank you for that.
Thanks, Councillor Martin. I've got Liz Plant next, please. Sorry, Councillor Plant.
Oops, that's fine. Fine, thank you. Thank you, Chair. Yes, well, this is obviously a really complex and wide-ranging area, has been said before. And actually, Councillor Wallace asked most of the questions that I was concerned about, because obviously the big thing for us as the Health Scrutiny Committee is to be assured that we are not in this position again. I'm looking at the yellow pages of your report. The statement says the Trust is completely committed from the staff who directly care for women through to the board to now fully rectify the situation, and has set itself an ambition to move out of inadequate to good within 12 months of the previous CQC visit. Now that would be really within we've got 6 or 7 months left, presumably from when they came in September. So, I mean, do we really, what I'm basically saying are we likely to actually achieve that ambition and actually to make that what is a big movement in the amount of time that is left, and obviously in terms of all the things that you've actually put into place. And as Sarah said, things take time to work. You know, you might put things in place, but they don't happen overnight. There's still the staffing issues. And that seems, I mean, it's an excellent ambition. Are you likely to achieve it? Thank you.
Sarah, do you want to start?
To go, yeah. So when I walked around the maternity units, I talked with the staff about that ambition, because it's really important that they are part of this journey. And we talk about trying to get a good rating by Christmas next year. So if you like at the end of 2021, and the staff are incredibly committed to that, and it gives them a really concrete goal to aim for. We are literally throwing everything we've got at this. I care so much about wanting to get our maternity department to a place where they're really, really proud of the care that they provide. So it's a really, really important ambition. So I'm confident that we're doing absolutely everything we can. I think that what we are beginning to see is, in the first few months, some of the work that you start doing, you don't really see the impact that it's having, inevitably. And we are, as Keith described, beginning to see some of the impact of some of the work that we're doing now. If they came back tomorrow, we wouldn't get a good rating. That's an honest answer. But we're not halfway there yet. And when I look at the work that we've been doing and the detailed plans that we have, I think we have every right to keep working with the staff on that ambition to achieve good by 22. You know, and actually, you know, we have to be humble along this journey. So there are bumps along the road, and when we come across a bump and our plans aren't delivering as much as they need, you know, we have to be humble and we have to review them and revise them, because that, you know, that's what you have to do on an improvement journey, is continually reevaluate, are the actions that we're taking having the desired impact and having a great enough impact. And we do that through the governance process that we've described every month.
Yeah, and if I can just build on that slightly, I mean, the CQC report was very difficult to read. The the thing that the CQC said to us that they didn't put in the report for obvious reasons was that they felt that we actually had a group of staff in our maternity units which were quite different to what they often find when they inspect maternity units, in that they really got the sense of the ambition and the desire and the commitment of the staff to change. And so we were starting from a position of the staff really wanting to work with us and to see improvement. And we've absolutely seen that commitment from staff of all groups to move this agenda forward. So I think we've got a staff group that's really ambitious, and we would want to be ambitious with them. It is a really ambitious aim. We may not be able to deliver it, but we're going to do our damnedest to make sure we get there.
Okay, thank you. I've got Councillor Martin Wright next, please.
Thank you, Chairman. And I'll apologise if I'm going to ask a question that's been asked, because I had a bit of Teams trouble, bit of IT problems. I've had to go offline and come back on again. So if this question has been answered, please forgive me. But I shall start by saying that the reason we're here today, the catalyst for all this, was the passing of baby Andrews and the critical coroner's comments, and of course the critical CQC rating of improvement, requires improvement and inadequate. So we all know why we're here. But I was a little disappointed at the time when this was all in the media, that the statement that came from the trust was a little plastic, delivered from in front of HQ down at the city complex there, and it certainly lacked sympathy, empathy, and, to be honest, sincerity. We're coming out with the statements which we always get when things go wrong within the NHS. Lessons have been learnt, measures are being put into place to make sure these sort of incidents are never repeated. We always get that. But can you reassure me that your maternity services are now safe, and what are you doing to let the public appreciate that your services are now safe? And the prevention of future deaths notice that was issued to you, what are you doing around that? Thank you.
Thanks, Martin.
Shall I start, Sarah?
Yeah, you start.
Thank you for that, and I'm very sorry if that statement came across in the way that you describe. There's nobody that's in the organisation that's not been deeply touched by this CQC finding and the Winter Andrews case. And I mean that across the whole organisation. The whole organisation has been rocked by the findings, and I know the exec and the board are deeply sorry for the experience that women have had through the maternity service. So I am very sorry if that came across in that way. I think in terms of the preventing future deaths, we had, as ever with PFDs, we had 60 days to respond to the coroner in terms of the answer that the answers to the issues that she raised. And the Andrews family have contacted us again following our response, and we have offered to meet with the Andrews family and to engage them with them in all the work that we've currently got going on, so that we can be clear that there is real change from what has happened previously. In terms of can we give assurances of safety, this is something that Sarah and I actually have had very significant conversations around. Maternity services internationally have situations in which, very sadly, both babies and mothers do not survive. And there's not a maternity service in the world that would be able to say that they've not had any untoward events amongst babies or mothers, and that's a sad but real situation. What Sarah and I can be absolutely clear about, and we have this, as I say, we have discussed this at some length, is that the service is significantly safer today than it was in October of last year. That every day practice is looked at and reviewed in order to make sure it is as safe as it possibly can be for the women using our service. And the plans that we have in place and the programme of work that we've got in place is to do our very best to make it as safe as any unit can be in the country or in the world. But we will not be able to eliminate all difficulty for babies or all difficulty for women, very sadly. If that I'm afraid is where we are. And then it comes down to how do we judge safety in that context. But our aim is to make it as safe as we possibly can, and we can give absolute assurance that it is significantly safer than it was at the time the CQC came last year.
Thank you for that, Keith. Are you happy, Martin?
Yes, thank you, and thank you very much, Keith, for that. Thank you.
You're welcome. Agenta.
Thank you, Chair. Thank you, Sarah and Dr. Gerling, for today's presentation and report. I must say that from Health Watch, this is perhaps the second or the third presentation that I'm sitting through, and it does feel that a lot of precautionary measures have been put in place and actioned upon, and work stream and work plans are changed at speed. That said, this is also the third report I'm sitting through where, and it's unfortunate that I'm having to raise it again, about Maternity Voices Partnership. You have put in your actions, completed an action plan that improving the links and with regular meetings. At the risk of being completely concise and precise, just putting regular meetings is really not good enough. Are you able to give us any assurance, or give me as a scrutiny representative from Health Watch an assurance that the voices that you are coming through these regular meetings are taken upstream? Because that was the request, that it has to be both ways. It's not just top down implementing a lot of measures, but it also listening to what the service users are telling you. And at this point, till now, I am really sorry to say I have not seen much evidence of that you are listening to the service users and you're taking it on board. So I would need to really like to hear more on that within your action plan, at what point are these things are going to be taken, what commitment is there that you are going to respond to what the service users are bringing to you at this meetings, and if there is any action plan. Thank you.
Thank you, Agenta.
Do you want me to start, Keith?
Yes, please do.
Yeah. Thank you for raising that. And I mean, you're quite right that was one of the things back in October where it's really clear that, you know, our relationship with Maternity Voices Partnership wasn't what it needed to be, and the effort, for want of a better way of putting it, from the organisation into that wasn't where it needed to be. One of the pieces of work we've been progressing this month is looking at all the patient feedback that we have for maternity and triangulating that from all the different sources. There is some really rich data there, and into the report there are some there is an increasing awareness of what that data is telling us, and an increasing response from the service one of the and we've done some workshops, with staff, helping to support them to get more involved and more engaged. One of the pieces of work that Carol, our new Director of Midwifery, is taking forward is that next stage, and I think she is arranging to meet with you to talk about how we can further the work with Maternity Voices Partnership. I wouldn't, and I hope I wouldn't want to give the impression that I think we have completely nailed patient involvement in maternity. I think we've made some improvements, certainly increased understanding among senior leaders about how important it is to be directed by the voice of our citizens. I've seen increasing evidence that when they're trying to change things, they're beginning to reach out better. So an example of that would be some of the work we've done recently around considering what we do about visiting. But you're quite right to point out it's not where to be in the end, and it's not at the same level that patient involvement is in certainly the other areas in my portfolio within nursing, where we've got very strong patient involvement groups. So I mean, your support and your help with getting us to where we need to get is really appreciated. And I'm very happy to meet up with you, outside of the meeting, if that would be helpful.
That would be helpful, Sarah. Might I just add that, while a lot is being done top down, if there is less focus on actually what I call as, health literacy, and that really has to happen, and that's falling short. And that if that engagement doesn't happen, then I suppose to some extent, you're not going to get where you want to be. So thanks.
Okay, thank you. Is there any response to that, or are we happy to proceed? Okay, has anybody that's not spoken want to make a comment or ask a question? Okay, I'll try and sum up best I can then. I think some of the language within both the report and talking about it at first was quite worrying for me personally. Long-standing concerns, large and complex recovery plan, compliance not being embedded. These are all, to me, red flags and warning bells going off, and that sort of thing needs, in my view, to be looked at. I have a bit of a concern about the relationship, or the possible relationship, between your maternity oversight committee and the service itself, because if you've got a specific group of people looking at the service, and yet that sort of thing happened, in my experience when I've been a governor of a school or things like that, sometimes the relationship between those doing the oversight and the service providers can be a bit friendly, a bit too friendly, and there's a reluctance to sort of put things forward where they're not happy with it. So I think that's definitely an area of concern of mine in terms of that relationship, and I think that might be something that you want to look at. Sometimes it's a pain in the backside to have somebody that criticises, but it makes you look at things. If you all sat around a table agreeing, it doesn't necessarily mean the thing is right to do. Yeah, so I think that's an area I'd like you to look at and maybe alter it. Get somebody in there who's a pain. It makes you look at what you're providing. It makes you question what you're doing, because I know that neither of you are here wanting to provide a bad service. The passion you've shown, Sarah, for this service has encouraged me that you want the right thing to happen. So we know that. Yeah, and Keith, and I'm getting to know you well, and I know you're passionate about what your role is and what you do. So absolutely, but get people. I get criticised by this lot on the committee, and I'm the chairman of it. So that's right, and that's right and proper, and that's how it should be in my view. And you know, as a committee, we want the best service possible for the people of Nottinghamshire. That's what we're here for. That's what we're to question. That's why we're to sort of pressure you to make sure you provide that. So I hope you take what I've said in good heart, really. I think we'd like you to come back clearly in June. Yeah, I'd also like the interim director of maternity to come with you at that point, so we can speak to that person and get a feel for what they believe and think and how it's going. And hopefully by June, I know it's quite close, but we should be able to see some more improvements starting to come to the surface. Obviously, with what Ajanta said, we want to see better patient engagement by then, so you can demonstrate that that's happening. And it would also be good to see the full recovery plan. Yeah, so I think if we're all happy with that as a committee. Yeah, excellent. I'm getting the thumbs up. So thanks. If you've got any comments, Keith, please come back now. I'm happy for that.
That's really helpful. Thanks very much, and thank you for the questions and the comments this morning. We'll certainly take those away and build those into the work we're doing.
Lovely, thank you. Thanks very much. That's it then for this meeting, and I'll see you in June. Thanks, Keith.
Thank you.
Thanks, Sarah. Right, that then takes us on to item 7, which is the work programme. Martin, you're going to introduce this.
Thank you very much, Chairman. Yes, so the next meeting of the Health Scrutiny Committee is on the 20th of April, and we have the Bassett Law engagement proposals, and that's the proposals that relate to mental health transformation in Bassett Law, which I think you heard about back in December, and that's the adults and older people's mental health services. We also have on the agenda the school nurses and family teams item that was requested by the Vice Chair, Councillor Wright. So that's on the work programme. I don't know if members have any other suggestions for items for inclusion, Chair. This will be the moment if they do.
Yeah, open it up. I think it works well that we only have the two items, doesn't it? I mean, as we can really delve into it. Councillor Martin, you've got a question.
Yeah, it's not so much for the work programme. I thought some of the public health officials might be here this morning. Can we find out if we're going to get a pop-up vaccination centre in Hucknall, because it's a population centre of over 40,000 people and seems to be lacking in that area.
Yeah, okay, I'll leave that with you, Martin. Yeah, if you have
Thank you, Chairman. I'll get colleagues in public health to address that and get an answer.
Lovely, thank you. Thank you. Councillor Doddy.
Yeah, I was just going to bring forward the item that you have on potential topics, which is public health item, and it was particularly around pre-diabetes. It was one of those things that last week we did an audit in the surgery, and we looked at the number of people who were pre-diabetic who became diabetic over 12 months of COVID. And the normal number of people is 5 to 10%, and we were up at 65 to 70%. So you had an extraordinary number of people through the activities of COVID becoming diabetic, 10 times. And then we looked at the people who were non-diabetic and became pre-diabetic, and those numbers were equally increased significantly. It's a hidden epidemic, it's a public health epidemic, and it'd be very interesting to see what the public health department is doing with regards to managing this. It's coming over the hill, and it'll affect everything, because you just heard from the maternity services of the complexities of the diabetic mother trying to give birth in a maternity unit, and it is big. So I see it's in the potential topics. If we get a little gap anywhere, it might be nice to just pull it forward, because I think we should be making gyms free. I think we should make swimming pools free. I think we should be making every possible effort to encourage people to get out and become active.
Yeah, thank you. I'm looking at June. Obviously, June's changed because we're going to have the maternity back in June. Martin, yeah? The 8th of June. God knows who's going to be on the Health Scrutiny Committee in June, because that's after the election. But if we give it the new scrutiny committee a task, what about? I mean, would we be happy? Assuming we're all the same people, would we be happy that 8th of June was maternity and diabetes? Would we all be happy with that? Anybody not? Sorry, Ajanta, you got your hand up.
Thank you, Chair. My hand was up before,
Okay,
but that's fine. That's fine. It was only to echo what Councillor Doddy has raised, that the same item, that can the pre-diabetes be brought forward, because we are getting anecdotal evidence of long-term conditions such as diabetes within primary care, and what's going to happen in the post-COVID. So that will be really good if it is picked up. Thank you.
Okay, I think we'll leave it there, because obviously, as I said, we don't know who's going to be here in June. So if we have it as the maternity in June and the diabetes in June, and just bump those two, Martin, into the to be scheduled.
Okay then. Okay,
yeah. Are we happy with that? Everybody happy with that? That brings us to the end of the meeting then. Thank you very much. Next meeting is on 20th of April. See you all then. Take care. Bye.
Bye-bye.
Thanks, everyone. Thank you.